Thank you very much for the kind introduction. So I would like to share my slide now. Okay, I hope everyone can see my slide. Good afternoon, ladies and gentlemen. Thank you for the organizer for inviting me to share my thought on this topic on spotlighting men's mental health. When I was given this topic, it's not a common topic we talk about, but unconsciously, as a psychiatrist working in the clinic, for example, we are commonly dealing with this kind of condition, and I have the thought that, for example, we are all the while we are focusing on the more toward women mental health. We pay enough attention on that, but we are not really pay good attention on the another sex, which is men. So I think I'm not sure. The question is whether men are from Mars and women are from Venus, which is, I think, my conclusion to some extent, to which is I will elaborate later on. I think that's probably a true fact because psychologically, mentally, we can see different features between men and women in dealing with general health issue, and also including in the mental health issue. So, yeah. So this is my introduction. So there's a very important consideration in terms of relationship between the sex and gender and the mental health situations of a people, of the person. So men's are can be seen significantly higher incident and prevalent of certain types of mental health than women. Where I will after this will elaborate on this and enlist conditions that show difference between men and women. And also in other fields, such as, this is another rationale why we look men and women in the different light, or we need to see in this way some difference between men and women. For example, in criminology, in the education, and also psychology, has shown distinction between men and women. So why it is important to see these differences? Of course, all the while, to begin with, the evolution in research, for example, we're looking at, like, for example, common psychiatric disorder or psychological condition similar to begin with. But as time evolved, as people more advanced, as research showed, there's some difference that need to be acknowledged between men and women, including in the mental health aspect. So why it is important? First, it is important for us to recognize this, to enable us to give effective intervention for the conditions. So the approach will be more tailor-made toward the needs. And in this case, we're talking about different gender between men and women. So it is important aspect to be considered, to be more specific when approaching men with mental health condition, for example. Secondly, as I will elaborate later on, we need to see how the barrier can be removed, especially for men, to access appropriate care. And when we're talking about, for example, barrier to access appropriate care, it is not a standalone, what you call, when we describe this, not isolated or isolated factor that we need to consider. It will interact with other factors as well. Will need to be dealt with comprehensively. And thirdly, it is important looking at the psychological aspect of coping strategies, especially we're talking about in men. And first, I will go to the specific condition that highlighted the importance of the difference between men and women. First, we're talking about suicide. Uh, so I have to quote from a Western study because that's more comprehensive, I would say. And there's a lot of required what they call needs to have our own local data as well. But in North America, for example, 75% of suicide are men, and 75% of substance use disorder were men too. So that look like, you know, it's a significant problems, you know, which is very biased. I'm talking not this is talking about the fact, so the more biased this kind of condition toward men. So really to address this issue, to have impact on the action on suicide, for example, or substance use, the as I mentioned earlier, the tailor-made intervention toward men, for example, need to be introduced. And to introduce that, of course, we need to understand these differences to make it more effective in the intervention. So suicide is the fourth main cause of death for people between age of 15 and 19 years old. And world rate suicide showed in men 12.6 in 100,000 population, whereas in women, in female, 5.4 people in 100,000. This is 2019 data which I quoted from WHO. Even in some population, men in certain ethnicity showed higher rate of suicide than the general population. This is, for example, in ethnicity African America. You know, this something to do with the what they call minority in that particular population. And so it is we call it silent epidemic for suicide in male or in men, because the public awareness still low, whereas the magnitude or the, if we don't address this issue, we are afraid, like for example suicide in our country, you can see in the newspaper, you know, like a lot of coverage about suicide were not been I mean, we hear now and then and more frequent these days, but do we have any particular plan to execute intervention to reduce these problems? And it is epidemic because it's a high incident and major contributor to men's mortality between in this particular productive age. And male suicide rate is 3 to 7.5 times that of women. Okay, and men who identify, for example, you know, this is talking about the character or the features, you know, of which type of men that have higher likely for suicide. For example, their character, for example, left reliance, you know, meaning they are not really sought, they don't seek any help, they don't like the intervention of other people toward their problems, you know, they consider their self-sufficient, you know, to address issues, whether psychosocial issue or emotional issues and so on. So it showed that 34% greater odds of reporting suicide thought in this group of men, and majority of men, about 67%, who attempted suicide prior to that particular survey, have showed the thinking about, you know, they're thinking about consequences toward the family. So in men in general, we're talking about they will have they will give other consideration, for example family, to which is might be we call it protective factor from them to repeat the act again. And men has another issue, men has insensitivity to pain and reduce fear of death. This is another um, explanation of the psychological explanation why men have higher tendency on committing suicide. So I just showed to you, shared with you some data, on suicide. We can see here, this is I take from the WHO report. We can see is male always been higher, like three times higher, slightly more than 3 times higher than female in terms of data of suicide. And then we're talking about it is across the what you call across the group. I try to move this slide. So if you see across different age as well, we can see the difference between male and female is similar. And I would like to attract your attention. You can see for the age of 15 to 45, male is much higher likely, I mean, in terms of prevalence of suicide, where, like, for example, 11 in 100,000 population for men roughly, but for female is around 3. And between 35 and 44, we're talking about 10.22 in 100,000 in male, 1.88 in female. This is much showed that during this productive age, of, I would say, 25 to 44, very important human resource in terms of their ability to contribute to national economic, and the suicide in males so strikingly a much higher rate than women. Okay. So this is some data talking about the absolute number of suicide. So that's the first part that showed significant and important difference to address, the difference between men and women in mental health, which is about suicide. And we need to recognize that. Second is on the substance use disorder and also alcohol issues. So it has been shown that for drug abuse, men has higher rate than women, and alcohol has greatest impact on men's mental health. And for example, I don't put here, but the paper on domestic violence, for example, which is predominantly attributed by men, and the rate of alcohol in case of domestic violence also high. And to make it more complex relationship as well, when just now I'm talking about suicide, they also showed that in case of suicide, the rate of alcohol in completed suicide also high, alcohol use disorder. And among things to explain this, for example, for suicide, I think it's not easy for one to commit suicide, to have completed suicide. But when they under the alcohol influence, for example, the bravery, the determinations, is impaired, and they might from somebody who fear, for example, to commit suicide, to jump from high rise, they just bridge this fear with the alcohol influence. So this is issue important to look at as well. And there's a tendency to use alcohol to cope with psychological distress, which I'm going to discuss later on, how men, because this is more to I would say coping with coping strategy in men, need to be addressed. And men's 2 to 3 times more likely to have a serious alcohol problem as well. And in 2004, the data showed that global deaths attributed to alcohol use as almost 6 times higher for men than in women. So of course, this is important to be for us to acknowledge for effective intervention. And in Canada, for example, 6.4% of men, while only 2.5% of women met the threshold of substance use disorder. So they take any type of substance. So it showed that 3 times higher rate in men compared to women. And the rate is also wide in between men and women. We're talking about when in terms of cannabis use disorder. So in a survey, it indicates that men have higher rate of general drug abuse, where men 0.9% and 0.5% for women. And for cannabis dependence, it showed around 1.9 for men and 0.7% women. And alcohol abuse or dependence, which is also, again, the data showed that men have higher rate. And 82% of death in the recent fentanyl crisis. Fentanyl is medications that easily been abused, and it can be very fatal if overdose, and showed that 82% by men. So the next mental health condition related when we talk about the difference between men and women is attention deficit hyperactive disorder. It showed that men have a higher rate in terms of having attention deficit hyperactive disorder. And in North America, for example, it is a ratio 2.5 to 1 in men, 2.5, and women in 1, and also can be as high 5.7 to 1 as well, the ratio. So it showed a significant propensity toward men again when talking about ADHD. And more interestingly, we're talking about ADHD, there are 2 types, subtype of ADHD. One is hyperactive, and the one is inattentive type. So when talking about for men, it's more likely toward hyperactive, whereas in women it's more inattentive types. And this is similar for the other disorders that been recognized in psychiatric. For example, disruptive and impulse control disorder, such as intermittent explosive disorder, which is more common in men. Also like other disorder, oppositional defiant disorder and conduct disorder as well, which is should higher rate in men. So I will describe this later on. I mean, because we're looking at this, I just give some information about the nature of presentation of illness. For example, when we see this oppositional defiant disorder, when talking about conduct disorder, we're talking about intermittent explosive disorder, we can lump them together as a way. For example, in men, they're more externalizing the problem that they have. So they display the mood problems or anything in the way that incoherent with what we call masculinity, the toward a man, as a man, for example, rather than internalize the emotion, where it's more common in women. This is the just now I mentioned like the intro. So like, for example, depression, for anxiety and depression, men have lower ratio than women. That's in the epidemiology of anxiety and depression, which is 1:2. for the anxiety and depressive disorder or mood disorder, if you lump this. But why this is so? Um, we this is how I'm going to elaborate this further after this. So it is in men, it is less likely to acknowledge or report the possible symptom of mood, and tends to judge, underestimate the problem, and they don't want to acknowledge, because acknowledgement of an illness might show a sign of weakness, for example, emotional, what they call emotional weakness. So it is against the understanding of masculinity in men. So the it's a there's a what they call it, the instinct in men, they're not going to disclose because it's again masculinity. And at the end of the day, depressive syndrome in men might be so-called mass depression. So they appear to be okay, they appear to be right. I'm talking about okay means, I'm not low mood, they keep calm, they try to calm themselves very much, able to perform their duty, they want to go to work, but they probably more sensitive person, they probably easily get upset, they more projecting their anger. So this is might be a sign that they are having depression. So it is not a typical way of presentation of depressions in men. And the description is, in women, there are more tendency act in or internalizing, for example, crying, talking over the things, and then they experience low mood subsequently. But in men, they tends to act out, externalizing with the, for example, will be perceived as a behavioral problem. And that's why, not surprisingly, I've done research in prison, for example, where they have so-called, when you go to prison, the behavioral problem, drug problem. Of course, they're majority men, but the rate of mental illness is quite high, and this is across other countries as well. It's similar finding. So it is important to address mental health in men, even though they are not presenting their symptom in the usual way, like in the women, the typical presentation. So they might have a different way. So act out more consistent with masculinity. Hence, no surprise, when they externalize or act out on their mood problem, they will go to impulsive behavior, they will take drug, and this end up dual diagnosis where they have mental disorder and at the same time they have drug problems. So this is another argument we're talking about. We say that the depressive disorder more in women just now, like 2-to-1 ratio. However, the suicide is more in men, as the data show as well. So there's the discrepancy between this fact, because the autopsy study, for example, in completed suicide showed that 50% of suicide, they have underlying mental problem, for example, depressions, quite a high percentage. So how to explain between these two? Another rationale why, to explain that depression in men probably manifested in different way, which is we not recognize using a standard measure that we use currently. When use the DSM-5, for example, for we use the DSM system, we probably emphasize on act in or internalizing. We're talking about mood symptom, we're talking about the crying spell, we're talking about unable to what they call reduce in speech and so on. So this is more internalizing presentations rather than externalizing like what required in men. So that's why in men is end up we're saying silent crisis for this. Another issue related to mental health in men is employment related issues. For example, unemployment has affected men's mental health than women, as shown in meta-analysis, which is men is twice affected by the unemployment. And possible reason, traditionally men is derived from his self-identity, self-esteem and self-worth as work to provide status, income, resources for himself or the family as a whole. And job security at the end of the day for men is important, and job security and conflicting between family and work responsibility were shown to be predictive of depression in men as well. Hence, unemployment can significantly a form of psychosocial stress. We can see now during COVID, many people not working, then that's correspondingly why we can see higher rate of suicide, for example, occurring during this difficult time. But the confounding factor may also related to financial strain that they face. And even level of danger within the workplace related to poor mental health in male-dominated industries such as coal mining, commercial fishing, will show higher rate of suicide, while white-collar occupations were evolving nowadays, more white-collar where women in the particular job or industry showed subsequently decrease of suicide in the few decades ago, and hence transition from manufacturing male-dominated industry, and now it's more like white-collar industry more dominant. So in terms of work, probably this has this factor employment have less contributing towards suicide compared to the early days. And in Canada, for example, highest male suicide rate in rural area of high employment issued in that way. Another issue when talking about men mental health is one study involving Canadian men and women found that the incidence of depression was nearly 4 times higher among separated or divorced individuals compared to those still in relationship. So men are twice likely to report depressive episode following the separation or the divorce. And divorce and romantic breakup are strong risk factor for mental health and suicide. Loss of social support and emotional connectivity in men following breaking up, like in this case, in relationship, because of in men they have smaller circle of family and friends, so the loss of so-called loved one, will affect the man significantly, as perceived as also losing the emotional support. And also is also associated when there's separation, they have children, and the custody of the children also given to the mother or to the woman. So this also somehow contributed to the deterioration in the mental health in men following a separation or divorce. So there's a data showed that you can see here, the rate of suicide, it follows the rate of divorce itself. You can see it's reflected in this particular graph. So another issue important to address is childhood adversity. So while more sexual abuse in girls, physical abuse tend to be more common in boys. Girls more responsible, more respond in traditional way, while in boys less easy to classify, because the behavior again externalizing. See, in the children they also behave in this way, and it developed, in the men, I would say, when they growing up as well. So this behavior might so-called behavior become part of themselves as respond toward the adversity what they face during the childhood. So they become delinquent, disruptive behaviors could drop out, binge drinking and risk-taking behavior. With this behavior, boys more likely to be labeled as behavioral social problems rather than we take them having depression or mental illness. Another issue, we're talking about the change in their life in men. So it also can affect the mental health. One of the interesting research has been done showed that paternal postpartum depression, usually we're talking about mother, maternal postpartum depression, which is wide coverage in the media, but when talking about paternal postpartum depression is not very much emphasized. But however, in this research showed that 10.4% of father have this problem, and the risk factor including first-time father, and it can develop at the first trimester and may exacerbate mother postpartum depression and development of children. So this is very important to reckon, especially as a mental health professional like myself. We always deal with the maternal what they call maternal postpartum depression, but usually we overlook the male side, the husband or the partner issue. So it is important to remind ourselves when we see postpartum depression, we have to address the partner, whether they also have problem as well with the mental health. So next is about utilization of health service, which is also different between men and women. So for example, in America, they showed that women twice are using mental health compared to men. And also in Australia, showed that more women seeing psychiatric help. And this lower rate in men is hypothesized in relation to masculine gender socializations, because the men more stoic. Stoics means, you have no difference if you're stressed or you're not you're under normal or you're under stress. So you don't want, in other words, you don't want to show you're under distress or you're under emotional problem. So this is the nature in men in terms of their socializing. And also the stubbornness and also self-reliance that I mentioned earlier when dealing with adversity, seeking mental health help is contradict with the notion of these masculine gender socializations. And seeking help for mental health may be seen as unmanly and sign of weakness. So when we do intervention, when we plan like mental health promotion, we have to look at this aspect to reach to the target group, and especially those who already not in the accessibility or in the treatment. And a recent review also showed that degree of individual adherence to masculine role norms negatively impact help-seeking behavior. Okay, and empathy gap, this is interesting thing. So empathy gap always been happening, where it has been shown that women with mental illness are presented much more sympathetically by the media than men with mental illness. And how men cope with distress. So this is the third part of my talk, and I'm finishing soon after these topics. So social gender norms and men's reluctance to seek help, and possible healthcare provider or health policy makers influenced by these gender norms, where men's reluctant to seek help. And the notion of masculinity are also unfortunately institutionalized in medical system. That means I haven't put, because it can be too long for this talk. So we're talking about clinician bias versus measurement bias in dealing with the gender issue in mental health. For example, what is the measurement bias? As I mentioned, I touched a bit earlier. For example, depression, we're talking more like on the internalizing presentation or acting in presentation. So it will detect more women with the mental illness compared to men, and men will be end up with the oppositional defiant behavior, conduct disorder, and so on, which is not captured as a depression, unfortunately. So the medical system has been understand this presentation through this way. And also another thing is clinician bias, where when the knowledge they have, they might stereotype in men. You know, for example, men is not they can, you know, are less likely to be depressed. You know, and when they are irritable, we say they are not depressed, but they might, you know, have a behavioral problem, anger problem, and so on. I mean, it could be true. Intervention, we have to probably deliver that way, but to tackle the root of the problem is also important to understand this part of the he has other mental illness, for example, depression or anxiety. And there's research showed that shorter consultation time with men than women, so this is probably clinician bias, and also fewer and briefer explanation given to men when they have illness, mental illness. Men are less likely to be probed for emotional and psychological problem. This already explained earlier. The study showed that dismissive and intolerant attitude by provider in suicidal men decision to use alcohol or drugs. So how men cope with the distress? Men tends to use a negative coping style, externalizing in nature to maintain their so-called to retain the masculinity as is in the social norm for men. So they might have a tendency misuse of alcohol and drug to numb distress, concealing and ignoring negative emotion, denying suffering, or absorb that all in, sucking it up, engaging in risky behavior, valuing the self-reliance and autonomy over professional care, and isolation or reducing social connectedness during the distress. And the research implies a knock-on effect where men do not perceive the need of care. Immediate support system do not identify male-specific warning sign. So that's in the system, the medical system just now. They're not able to detect the main mental health problem. The diagnostic criteria do not detect men with mental health problem, and men delay treatment until the problem become probably so-called in the crisis way. Okay, so this is my last slide. So the conclusion, evidence suggests that individual men may needs to change. The person itself have to change, you know, the man, in other words. So how to change? They must be given knowledge, and they recognize this is their condition, and they need to do something about it rather than, you know, retain the coping skill that's not healthy. However, health service provider, so that's another responsibility, not only that individual, because they are probably have mental health problem, but the provider also and society as a whole may also need to change, looking at them, especially the clinician, the mental health fraternity. This approach may help address that many are calling the silent crisis of men's mental health, addressing coping strategy in men that are dysfunctional, which may become vulnerable to negative physical and psychological outcome. Need to be addressed all this. We need also to have clinical practice which is sensitive to expression of mental health problem in men and respond in the relevant manner. So with that, thank you for your attention. I pass back to the host.
Thank you, Dr. Muhammad Musin, for your insightful presentation on men's mental health. Before we continue with our next session, let us take a short 5-minute break, and we'll come back at 3:30.